Hello, everyone. Thank you for the kind invitation for me to speak at the Libyan International Emergency Medicine Conference. And I'm honored and with great pleasure to deliver my presentation with the topic on endocrine emergencies and probably dwell on some of the things not to be missed in critically ill patients. So for this presentation, I will be presenting to you 10 cases which involve endocrine emergencies, and that would include a hot lady, a wheezy storm, baby storm, drowsy cold throat, a withdrawn lady, too much on my heart, wicked dry cough, hunger for air, the SOB child, and a drowsy drunkard. So let's go to case number 1, a hot lady. So there's a 24-year-old Chinese lady who presented at our center with palpitation and sweaty. She had a vomiting and was restless. On examination, there was a neck swelling and also the eyelid appear puffy as well. The vital sign showed that she was tachycardic at the heart rate of 120, a bit tachypneic at 32 breaths per minute, and with the temperature of 40 degrees Celsius. There was also crepitations on the right lower zone of the lungs. So, this lady seemed to be having thyroid storm, and with the Birch and Watowski scoring, we calculated that it was more than 45. And if you notice, the Birch and Watowski score revolve around these 4 systems. That is the central nervous system, the thermoregulatory system, cardiovascular system, gastrointestinal system, as well as a precipitating event. And for each system, you could see that the score increases according to severity. For example, with the CNS, from agitated to seizure, thermoregulatory-wise from a low temperature to a high temperature, cardiovascular from tachycardia all the way to congestive heart failure and even atrial fibrillation, and gastrointestinal system from a simple nausea up to diarrhea and even jaundice. A score of more than 45 is highly suggestive of thyroid storm. So a clinical diagnosis in patients with pre-existing hypothyroidism, and you could diagnose the thyroid storm based on the presentation and with such scoring of more than 45, and the treatment should start upon a suspicion of diagnosis. So in this patient, the ECG showed sinus tachycardia. Paracetamol was given for fever. Beware of giving aspirin for such patient, because aspirin could dislodge the binding of thyroid hormone from globulins and worsen the thyroid storm. For this patient, propylthiouracil 600 milligram is given, and it functions to inhibit the thyroid hormone production, and also it has the advantage of stopping the conversion from T4 to T3. The T3 is the more powerful form of thyroid hormone. And IV hydrocort of 100 milligram was given, and the intention is to inhibit the conversion from T4 to the more powerful T3. IV propranolol, a beta blocker of 1 milligram was administered. This is to control the tachycardia, and it has the advantage of stopping the T4 to T3 conversion as well. After 1 hour of giving propylthiouracil, the drug that inhibits the synthesis of thyroid hormone, Lugol's iodine 10 drops was given, and this is to inhibit the thyroid hormone release. So in other words, what we do in treating thyroid storm is at multiple levels. First, we stop the synthesis by giving thionamides in the form of either propylthiouracil or metimazole, or in some places whereby you do not have metimazole, to give carbimazole. And you stop the release with the iodine, and you stop the conversion from T4 to the more powerful T3 with propylthiouracil steroids and propranolol. The T3 hormone is 4 times more powerful than T4, and 85% of this hormone comes from a converted T4. Now, the outcome for this patient, the heart rate went down to 112 per minute, BP stable, blood culture sensitivity sent, then the chest x-ray showed there was haziness over the right lower zone, and a diagnosis of community-acquired pneumonia was made, and IV augmentin was started to treat the infection, apart from the rest of the management for the thyroid storm, and patient was admitted to the ICU. And investigation results later showed low TSH and high T4, confirming the diagnosis. Do not forget to always find and treat the cause or trigger of thyroid hormone. There are so many triggers. Yeah, even delivering a child also, if one has a hyperthyroidism, can get someone, that person, into thyroid storm. But the most common cause of thyroid storm currently is infection. So for that patient, the thyroid antibody titer was positive, and the patient actually has a grave disease. And she was discharged to normal ward 3 days later, and after 2 days discharged home with carbimazole. Okay, case number 2, wheezy storm. Well, a 25-year-old lady presented with palpitation, anxiety, sweating, fever, and vomiting. And patient was a known case of bronchial asthma. On arrival, she was tachycardic, and there was a temperature of 40 degrees Celsius, otherwise stable. But on examination, she has goiter and tremor. Well, the lungs were clear on auscultation, and the Bershon-Watowski score was 47. And patient was treated with propylthiouracil, hydrocortisone, beta blocker, and later iodine as well. Well, propranolol was given, and shortly after, patient complained of shortness of breath and started to have wheezing. So the propranolol was withheld, and heart rate was 133, was given nebulized salbutamol, and after about 2 hours, the heart rate went down to 90 per minute. So the diagnosis of thyroid storm with acute exacerbation bronchial asthma was made, and was likely precipitated by the propranolol given. So for such patients, just beware that they may get asthma exacerbation if given beta blocker. There are alternatives in the form of rizapine or guanitidine. So there are also some alternatives for those who are allergic, for example, to thionamides and iodine. For example, if one is allergic or cannot be given propylthiouracil, an alternative is lithium. Lithium can inhibit both synthesis and secretion. So it could help also in place of not only propylthiouracil but iodine at the same time. We just have to be careful about the lithium toxicity if we do give them. And the oral lithium 300 milligram 8 hourly is generally safe, and lithium level needs to be taken and monitored. Okay, we go to case number 3, baby storm. A 32-year-old Malay lady with the known case hyperthyroidism, G3 para 2 at 8 weeks of pregnancy, presented with palpitation, fever, tremor, diarrhea, and was restless. Patient was tachycardic, and there was a temperature of 40.5 degrees Celsius. So the medical officer called the consultant and said, this is thyroid storm. I'm sure this is thyroid storm, but boss, this patient is pregnant. Can we give this anti-thyroid medicine for the patient? Well, these are all the drugs that can potentially be given to patient having thyroid storm, but we just need to know whether we can use them. Well, if you go to and check the pregnancy safety class, you will find that steroids and beta blockers of class C, and the rest, propylthiouracil, metimazole, lithium, and others, are of class D. So what is class C and class D? Class C means that there are adverse effects on fetus in animal studies. For category D, there are evidences of human fetal risk. These are the concerns. Nevertheless, for both class category C and D, the benefits, the potential benefits may warrant the use in pregnant women. So the decision to start these medications depends on the clinicians as long as the benefit is warranted. So you can give. The only thing that one has to be careful is that the choices of thionamides, whether propylthiouracil versus metimazole or carbimazole. So propylthiouracil is safer compared to metimazole or carbimazole in the first trimester because both metimazole and carbimazole are teratogenic. So for first trimester, go for PTU rather than metimazole or carbimazole. However, if patient has a liver disease, do not opt for propylthiouracil, go for metimazole or carbimazole. So there had been cases of fulminant hepatitis with propylthiouracil. So be careful. If patient has signs and symptoms of chronic liver disease, just avoid PTU. Okay, so yeah, PTU can cause liver failure, but it's quite rare, but it can. And as I said, metimazole, carbimazole are both teratogenic. So this patient was given propylthiouracil in view of being in the first trimester of pregnancy, given hydrocortisone, propranolol, and iodine, admitted to the ICU as well, and discharged home 6 days later. So in thyrotoxicosis, in severe thyrotoxicosis, one may have atrial fibrillation, but in general, the anticoagulants used could be used for the patient. As for digoxin, it may be good also for heart failure patients, because in thyroid storm, some of them do get in the state of heart failure. But just beware, it is usually not responsive without the use of anti-thyroid treatment. So you need to start your thionamides first, and then the digoxin will be more effective. Well, as for amiodarone, in view of some of these patients may get into fast AF, for example, well, if it is to be used, make sure that the thionamides had been given first, because it contains iodine, and as we know, iodine is only given after at least 1 hour of the thionamides being given, after the blockage of the synthesis started. Yeah? Okay, now we go to case number 4. Well, I call it a drowsy cold toad. Well, a 46-year-old Malay lady with a history of thyroidectomy on thyroxine replacement therapy, but missed her medicine, and presented to our center with altered consciousness, both legs swollen, and they are non-pitting. Vitals, in terms of the blood pressure, was low. Patient was bradycardic and even bradypneic, and the temperature was low, 36 degrees. And there was also hypoglycemia with a glucometer showing 3.9 millimole per liter. So for this patient, the glucose was corrected. And in view of the patient already known case of hypothyroidism, that's why I call it a drowsy cold toad, and presenting to us cold and bradycardic, we started back the patient's thyroid replacement in the form of levothyroxine. And patient was given the treatment, and after an hour, the BP improved, the heart rate improved, and even the temperature also. Patient regained the state of consciousness and was admitted, and was put back on thyroid replacement therapy and discharged 3 days later. Okay, now case number 5, too much on my heart. A 72-year-old Indian lady with a history of thyroidectomy for carcinoma of thyroid. Patient also had ischemic heart disease, but defaulted follow-up. So presented to the emergency department with altered consciousness, and with the vital signs shown BP low, heart rate bradycardic, also bradypneic, and cold with a temperature of 35.5, and dextrose was low, i.e. hypoglycemic. The ECG shows sinus bradycardia. So patient was given atropine, and dextrose was given, and was given hydrocortisone and liothyronine thyroid replacement in the form of T3, which is more powerful, of 20 microgram was started. And there was fast response. The BP normalized, the heart rate also went up, the respiratory rate improved, and the temperature also normalized. And consciousness was also improved. And suddenly, patient complained of chest pain, and the ECG shows ST depression at the anterior segment, and the echo showed hypokinesia at the anterior segment. So patient was treated as having acute coronary syndrome, and it was likely because of the levothyroxine, which was more powerful when given to elderly patient. This T3 or liothyronine is powerful, but it could actually be too much for the heart. So it works faster, but just be careful for elderly and those who have coronary artery disease. It could precipitate acute coronary syndrome. So for those patients, it's better to give levothyroxine or T4 rather than liothyronine. Okay, case number 6, we look at a withdrawn lady, a 50 years old Malay lady, known case of chronic severe asthma on prednisolone, but she stopped taking steroid for 1 week and presented with general weakness, altered consciousness, low BP, bit tachycardic, temperature normal with a hypoglycemia. The sodium is slightly low at 133 and the potassium was normal. So in view of patient stop taking the steroids, so it's quite likely that this is due to steroid withdrawal. So patient was given dextrose and BP remains low. And after given hydrocort 100 milligram, the BP normalized. So this patient has actually adrenal crisis secondary to steroid withdrawal. So the most frequent iatrogenic causes that of acute adrenal crisis is the rapid withdrawal of steroids in patients with adrenal atrophy secondary to long-term steroid administration. So be careful for those presenting with low BP but already on long-term steroids. Okay, case number 7, wicked dry cough. So I call it a wicked dry cough. A 45 years old Indonesian gentleman presented with general weakness with a history of night sweat and cough. There was non-productive cough for 1 month, and upon presentation, the BP was low at 70/45. The heart rate was 100, was normal temperature. Sodium was very low, 118. Potassium 5.3, and normal glucose. As he progressed, BP improved to 82/55 with dextrosaline solution. IV hydrocort 100 milligram given, and BP normalized. Patient was admitted, and month 2 test was positive. The chest X-ray confirmed it was very much typical of TB, and ultrasound showed abnormal mass over left adrenal gland above the kidney. So anti-tuberculosis treatment was started. So TB or tuberculosis is the most common infective cause of adrenal insufficiency worldwide. In the US, HIV is the most common cause, and 50% of HIV patients show some degree of destruction of adrenal gland, but only after the gland's functions less than 5% does it show symptoms, the form of the low sodium and also low blood pressure. And 20% of AIDS patients would eventually develop adrenal insufficiency. Okay, case number 8, hungry for air. A 42 years old gentleman, alcoholic, present to the emergency department with shortness of breath. Kussmaul's breathing was noted, smells of alcohol, and upon investigation, the atrial blood gas showed the pH of only 7.15, and the bicarb was pretty much normal, 22. The dextro-6 was 4.5, so it was initially thought that this could be a renal failure, but the urea was only 6. The creatinine was 115, and the ketone was 6. So for alcoholic patients, they can get euglycemic ketoacidosis. So for this patient, IV dextrosaline was started. The blood gas normalized the next day. So basically, what happens is that patient has impaired liver function and could not generate enough glucose in, and they are essentially in starvation. So ketone bodies produced. That's why patient had high ketone. So what they need is just glucose-containing solution. Okay, case number 9. The SOB child. Okay, we go to a child, a 5 years old child brought to the emergency department by the parents, complaining of shortness of breath. There was no history of cough or trauma. The airway was clear. Dextro-6 showed 24. And blood ketone was 5.2. And this patient was diagnosed to be having a newly diagnosed diabetes mellitus and in a decade state. So insulin infusion was started, and fluid bolus was given at 20 mL per kilo times 2. And then maintenance was started for 24 hours. So child subsequently became drowsy, and CT scan was done, and it showed cerebral edema. The diagnostics also came down to 3.9. So for child, the management is a bit different. We cannot go too rigorous, too aggressive with the child, and we should do it slowly. Do not start insulin immediately. At least give a bolus of 10 mils per kilo over 1 hour, and then only repeat the blood glucose. And some you may not even have to start insulin. But in this case, insulin was started much earlier, and child ended up having cerebral edema in view of developing hypoosmolarity. So what should be done is that there should be a correction of dehydration of up to 8 mils is enough, of 8% is enough, sorry, and then provide the maintenance fluid for a period of 48 hours. We can go with slow correction. Okay, now case number 10, the last case is what I call drowsy drunkard. A 43-year-old alcoholic was assaulted, had loss of consciousness, smells of alcohol. GCS was only 12, and CT scan done was normal. Was admitted to observation ward, and the diagnosis was cerebral concussion in view of the assault. The next morning, patient was still drowsy, and dextrose audit showed 3.9. Dextrose 50% 50 mils was given, and patient recovered. So it's just that one has to remember, sometimes you get confused from assault when the patient is actually alcoholic, and they may have problem with glycogenolysis, gluconeogenesis, and glycolysis, and they can be in a state of low dextrose, low sugar, and that could be dangerous if the glucose not checked. And failure to pick the risk may pose danger to the patient. So that's all, 10 cases, and what we had talked about today is the number one on the thyroid storm management, for which basically what you do is to block the synthesis either with propylthiouracil or metamazole or carbimazole, depending on the patient, whether the patient is pregnant or having liver disease. Block the release, for which you only block after the synthesis has been blocked. So that's why iodine is to be given 1 hour after the synthesis is blocked. And to reduce the T3, the more powerful T3 conversion by the use of steroid, propylthiouracil, and beta blocker, and to block the beta receptors with beta blockers. But be also aware of the alternatives for those who could not take the medications. So alternative for thionamides and iodine can be in the form of lithium. Alternative for beta blocker can be in the form of rizapine and guanidine. Anti-thyroid drugs can be given to pregnant ladies. They are of category 3, category C and category D, depending on whether the benefit outweighs the risk. Just be careful not to give metimazole or carbimazole in the first trimester pregnancies. They are teratogenic. Beware of using liothyronine or IV T3 for elderly patients or those having heart diseases, because this can precipitate heart attack. When BP fails to rise in those on previously treated with steroid, or those having TB or HIV patient, just give steroids. And steroids is also a universal treatment for all thyroid and adrenal crisis, whether it's a hyperthyroid storm, myxedema crisis, or adrenal crisis. Just give steroids. And all crises has triggers. Our job is to search them and correct them. So in summary, euglycemic ketoacidosis. Another one is that euglycemic ketoacidosis. It can happen in those having in alcoholic patient. Treat this with a dextrose-containing solution. And remember, for child with DKAs, treat with slow fluid and insulin. Don't go too fast, for patient can develop cerebral edema. And remember, hypoglycemia and chronic alcoholics. Don't forget to check, because you can get a patient having neuroglycopenic coma if you do not check the glucose in this patient. So with that, I thank you and wish you to have a great conference over there in Libya. So thank you. Terima kasih.